Okay, well, I think we can get started. My name is Rebecca Snow, and I'm the project coordinator at CHAMPS. And today, thanks for joining us for our Wednesday webinar, where we're going to talk about the Mother's Milk Bank of Mississippi. And Linda Pittman and Rebecca Sayans are going to be presenting in just a minute. But first, I'm going to give some updates about CHAMPS before we get started. And just a reminder to everyone to please mute your line. You can do it on your phone just by pressing the mute button or by pressing *6. And just don't press hold because then everyone will hear your hold music over the phone. And then if you need to unmute to ask a question, you can hit #6. And we'll take some questions at the end. Okay, so first just a quick update about CHAMPS. This is our first Wednesday webinar since we've been renewed funding for an additional 3 years. So first we had the first grant was CHAMPS South, and that was 2014 to around July of this year. And then now, and that was focusing in Mississippi, New Orleans, and some hospitals in Texas and Tennessee. And our new 3-year funding will focus just on hospitals in Mississippi. And so in our first wave 1, we had 18 Mississippi hospitals, and currently we have still those 18 from wave 1 and then 14 new hospitals. So we have a total of 32 Mississippi hospitals in CHAMPS right now, and we're still taking applications from hospitals to enroll. So if you are from a hospital or know somebody from a hospital that's not in CHAMPS, send us an email at champsbreastfeed@gmail.com, and we'll get in touch with you about applying. So here's a map of Mississippi, the hospitals that we have enrolled. The gold stars are the hospitals that were from wave 1 that are included in wave 2 as well. And the blue dots are the new hospitals that are added for wave 2. A couple of notes about CHAMPS conferences. We just had a conference in September for hospitals that are newly enrolled or hospitals that are interested. And we just posted the slides from that conference on our website, cheerequity.org/conferences. And then Dr. Meerwood, the director of CHAMPS, will be presenting at the MSPQC meeting on November 3rd, and that's in Jackson. I believe the registration is still open for that. If you go to the MSPQC website, you can find more information about their meeting in November. And we are planning a conference for early April of next year, and that will include all CHAMPS hospitals, not just the new ones. So it will be the ones that are currently enrolled as well. So stay tuned for that. Check back on our website or on our Facebook and Twitter pages for more information about that coming soon. We also wanted to mention some upcoming clinical skills trainings that we have in Mississippi. So far, CHAMPS has hosted 48 trainings in 20 hospitals and has trained over 800 Mississippi-based clinicians for this 4-hour clinical skills training. And we do have one 15-hour training coming up, but actually the registration is full for that. But we have several 4-hour trainings upcoming in the next few months, and online registration for that is on our website, cheerequity.org/training. So you can find more information about the locations and the dates and times and register your staff for those on our website. Before we get started with this webinar, we just wanted to mention the next few webinars that we have. Next month, November, we have a webinar on November 29th, and that will be Dr. Lori Feldman-Winter talking about becoming a breastfeeding-friendly office practice. And then in December, we don't have a date set yet, but Baby Friendly USA is going to talk about their recent changes to the fair market compliance options. And so the login is the same for this webinar, same time, in the next couple months. And also the slides and recordings for this webinar, previous webinars, and upcoming webinars will be on our website as well on the webinars page. So that's all I have for updates for CHAMP. So we can go ahead and get started. Linda Pittman and Rebecca Sayens are going to be talking about the Mother's Milk Bank of Mississippi. Just a reminder for anyone who just signed in to mute your line. You can press the mute button on your phone or press *6. And don't press hold because the music will play for everyone. And if you need to unmute for any questions, you can press #6. So with that, I'm going to turn it over to them. Let me just give you the presenter privileges here. Doesn't seem to be working. Let me try again. Well, there we go. Okay, you guys should have control of the slides now. Perfect.
Welcome everyone. Welcome everyone to the Mother's Milk Bank of Mississippi. This is Linda.
And I'm Becky. The reason that we were asked to present today is because different people in their different clinical capacities and outlying hospitals and CHAMP hospitals and also clinics kind of need to know how milk banking works and why. And even if you don't work directly in a NICU with premature babies, you might come into contact with mothers who are donor mothers or with mothers of premature babies or NICU graduates who might have questions about milk banking. You may see premature babies in your practice. Their mothers may have questions about where the milk comes from, how did it get to their baby. There may be confusion about the difference between what milk banks do and about milk sharing or buying milk over the internet. Periodically that makes the news. They may have questions about the difference between a for-profit milk bank versus a non-profit milk bank that's affiliated with the Human Milk Banking Association of North America, as we are. You may be dealing with a mother of a patient who has oversupply and wants to know what can she do with all this excess pumped milk that she's got in her freezer. Milk banks may also periodically ask for your approval as a clinician working with either the mother or the baby in your care for them to donate milk. That's a process that we have. It's part of our checks and balances system to make sure that we are getting healthy milk. And finally, the mothers of babies in your care may actually have questions about donating their milk and how to go about that and how to connect with the milk bank. So that would be why some things that you might, some reasons you might come into contact with donating mothers and or babies. And we hope we can answer those questions for you. So why would a hospital give donor human milk to its premature babies? Well, because moms can have difficulty pumping enough of their own milk after a premature birth. Their breasts weren't quite ready to breastfeed even though the baby needed to come early for some reason. They might have had preeclampsia. A lot of the medications that are used to treat that prenatally can hinder the milk supply coming in as rapidly as they would like. Some medications that they're on may be contraindicated while they're on them for their particular baby. Even stress, the stress of preeclampsia or, an emergency birth, C-section for some reason can inhibit milk coming in quite as quickly as we would like. And hopefully CHAMPS is doing away with this last one, this inadequate support thing, and that won't be an issue for much longer. But in previous days, sometimes moms didn't get the information they needed in the early days to get started pumping adequately soon enough. So that would be some reasons why the baby might have a higher need for milk sooner than the mom has a supply to meet that need. Donor human milk is their bridge between when the baby's needs go up and when the mom's milk supply follows suit. We're never intending to substitute for a mother's own milk. However, we have noted before, and it's been noted in other locations, that anytime a mom is asked to pump, and there's donor human milk being given to the baby instead of formula. She realizes how important human milk is for her baby, and she also realizes how important it is for her to go ahead and do everything she can to maximize her own supply. It's also been noted, of course, that babies are able to advance speeds faster than mom's supply increases, as we've said, but giving human milk that's donor milk avoids the exposure to foreign, meaning non-human proteins and some of the autoimmune difficulties that can crop up later in life when artificial human milk has been given from with proteins from another species. So, the reason that milk is now banked instead of just casual sharing is that milk banking, as opposed to casual sharing or selling or getting milk from your neighbor, minimizes the risk of transmission of infectious disease. It prevents the risks known to be associated with formula use, particularly in the NICU. There's a high risk in premature babies of necrotizing enterocolitis, also known as NEC, and also of sepsis because of the hospital environment. And human milk, of course, can help prevent those things. In human milk banking, most of the nutritional and other components, growth factors, glycoproteins, and so forth, are preserved in our pasteurization process. And of course, because as a human milk bank with a credentialing agency, we do have standardized procedures for screening, processing, testing, and dispensing to be sure that the milk is as healthy as possible. So anything to add to that?
The part about transmission of infectious disease and the casual sharing, we have found that there's studies have been done when casual sharing is happening. You don't always know that donor. You may think it's your best friend and they're perfectly fine. But in our testing our own donors, they do have to go through some blood testing, and the past few years we've actually had 3 potential donors who tested positive for some things they had no idea, and neither did their health care providers know. So you really don't know unless you actually do the blood test.
The Human Milk Banking Association of North America is our credentialing agency, and this is a network of all of the nonprofit milk banks in the U.S. and Canada. Their function is to develop guidelines for practice in North America. They provide a forum for sharing information among the experts in the field. They act as a liaison between the milk banks as a whole and government agencies, particularly the FDA. They facilitate communication among member banks, and they assist communities in developing milk banks. Every developing milk bank has a mentor that helps them get through the process. HIMBANA also conducts our yearly re-credentialing process. We have an inspection every year, and they also hold scientific meetings every year that we can attend for the latest in research. Our staff here at Mother's Milk Bank of Mississippi consists of our executive director, who's Linda Pittman. We have 2 medical co-directors, myself and Botham Weedy, who we had hoped would join us today, but she has had a family emergency and is unable to join us. This year we have hired a donor mom coordinator named Lou Miley Griffin. We have 3 volunteer pasteurization technicians and 2 that are now employed with us, and their names are there. Just for a minute, let's talk about what a donor milk bank isn't, because there's some misconceptions, even among healthcare personnel sometimes, about what a donor milk bank does and doesn't do. We're not just a matching service. We don't just say, hey, if somebody's got some milk, let's store it in our freezer for a little while and we'll send it to somebody who calls in and says they need some milk. We get calls periodically from moms saying, I need to supplement my baby and I want it to be with human milk, so how do I get milk? And that's not what we do. So we're different from an online milk selling site or a milk sharing service. We are part of the nonprofit milk bank network that has the formalized procedures for making sure that the milk is safe, and then also we have an ethical hierarchy of how we dispense, with the NICUs being at the top of that. So what do we do? I'm going to turn this part over to Linda because she's the one that oversees all the day-to-day operations of this around here.
The donor screening starts with an over-the-phone interview that Lou or I do with a potential donor mom. That is just a little bit of an overview with health history questions, some travel questions, and medication questions. And if they pass that, we send them a much more expanded version of that information. There are like 8 pages. Most of that is just checking yes or no. Some of the same questions that we ask on the phone interview. The reason for repeating this, sometimes they will forget to tell us something over the phone, but when they see it in writing, they'll go, oh yeah, I forgot to say about that. So it's very extensive. We send them a lab slip. We have contracts with both LabCorp and Quest Labs across the state, and we pay for the lab work. The mom does not have to pay. She just has to go have her blood drawn. And so we send her a lab slip for that. Part of the paperwork, as Vicki mentioned earlier, one form will go to their delivering physician, and the other one to her baby's pediatrician. All she does, the mom does, is she signs those, giving the healthcare providers permission to release information to us. So we're asking them some of the same questions we've already asked her, but we want to hear it from them also. So that's the initial screening. Once we approve her, we get all of that back, our blood tests back. I review their files. Becky reviews their files, and when we can say, yes, they are approved, then we receive their milk either here at the main milk bank or at one of our collection sites, depots across the state. We pasteurize the milk here in the lab, where there are very strict guidelines for how we do that. We're going to show you some pictures of that shortly. And after the pasteurization, 1 bottle out of every batch will go to a local hospital lab for cultures. So that milk cannot be released until we get the negative cultures back on it. Those are who our donors are, usually healthy mothers who just have more milk than they know what to do with. This time of year we hear a lot of, my husband said I had to get rid of this milk out of my freezer because he's going deer hunting. And so we will gladly take that. And then we do have some bereaved moms and moms who had already been saving some milk for their own baby, and that baby passes away. And the only thing that's different about their screening and what's required of them, we have a minimum of 100 ounces of milk that we accept from our regular donors. With the bereaved moms, we'll take whatever they've got. You'll see there the list of all of the things that we do test for on our blood test. And the 3 things I mentioned earlier that we've had positive have been 3 different things. So it's been an education for both us and some of our healthcare providers when we've gotten those back as a surprise.
Yeah. One of the things that's on the OB form that we ask them to fill out is about the mom's prenatal lab work for these same tests as well, so that we can know if she's like a new seroconversion of one of those infectious diseases or not, and that gives them, when we turn that back to them, if if we get a positive, that gives them a little bit of an idea about how to go about treating that. We ask for the pediatrician's approval because sometimes the pediatrician will know a reason that the mom shouldn't donate that maybe she didn't tell us on the form. Like, for instance, if they have noted that she's a heavy smoker, but she didn't note that on the form, there's a place for them to write that in. Or if the baby is not growing well according to their records and they have some concerns about her donating milk when really the baby needs to be getting more of her own milk, they can note that. Donors are not eligible if they smoke or use any tobacco products, if they have a chronic health condition, if they are at risk for AIDS or HIV, if they are a household contact for someone with hepatitis, if they've been treated for tuberculosis, if they don't meet the blood banking travel guidelines, or if they take certain regular medications. Now, we do allow, if a mom is on insulin, heparin, a low-dose birth control pill, vitamins, and most nutritional supplements, although there are some of those that are exclusions as well. Alcohol is not strictly prohibited. However, we do tell them that they may not collect milk for us for 12 hours after the last ingested alcoholic beverage. Okay, getting into the processing milk.
First thing that our techs do when they come in the lab in the morning is they have to scrub in as if they were going to surgery. Cap, mask, cover apron, and scrubbed up. This is not a sterile procedure, but a super clean food processing kind of procedure. So you see that's one of our techs there scrubbing in the morning. When they open the milk, and we thaw it overnight, and when they come in the morning, they open the individual containers and they strain that into glass beakers. And then from that, then that's transferred to glass flasks. And as we pool it, let me just mention something about pooling. The first time we run a donor, we totally run her by herself. We're looking for two things. We want to be sure approximate calorie count on her milk as a pool of it. Doesn't mean it's going to always be that, but it does give us some guidelines. And the other thing is to get a culture on just her. Now, if she comes back with a negative culture, the next time if we still have some of her milk, we're going to pool anywhere from maybe 3 to 5 different donors together. And I always give the analogy, if you think about that, milk that you buy for yourself at the grocery store didn't come from just one cow. It came from a pool. And so you end up getting a lot more benefits of the different donors. From having it in the flask, and there are procedures they use to move it from flask to help to try to get it more evenly distributed. Then it's poured into bottles. Then we put it into the pasteurizers. They're heated to 62.5 degrees Celsius. And then once you get to that temperature, they're held at that temperature for 30 minutes. After that, the milk is then taken out and put into an ice slurry where we get the temperature down quickly to like 4 degrees.
At the end of that process, there's a sample that's taken. One bottle gets sacrificed, and there's a sample that gets taken for bacteriological cultures at our local lab at one of our partner hospitals, and also a sample gets sent to one of our sister milk banks for nutritional analysis.
Then the milk goes into one of our big commercial freezers. We now have 3 of those. and it is all labeled not to distribute that particular batch until we receive the cultures back.
Once we get the cultures back, and that takes generally 48 hours, then that milk can be released from quarantine, as we call it, to be able to be used to fill orders at NICUs. In the meanwhile, during that 48 hours, we will have gotten the nutritional analysis back and put that label on the milk as well. Once we get an order from a hospital, then it can be shipped frozen overnight by FedEx to hospitals. At this point, we're not serving individual recipients at home, but we hope to in the future.
And this is one of the things that's exciting for us, to be able to work with different collection sites around the state, and we're working with several that aren't official yet. But it gives the mother who lives not close to us here in Flowood a place that would be more convenient for her to drop off her milk. And then we have a wonderful relationship with the people who run our depots so that they can then either ship us the milk. There's one of our depots that's actually close enough to us that most of the time we actually make a trip down and pick the milk up. And those are our current ones. Memorial Hospital at Gulfport, Forest General in Hattiesburg, North Mississippi Medical Center in Tupelo, Mom2B in Columbus, that is a maternity store that is owned by an obstetrician and her husband. And Oxford is the lactation station, which is a place where moms in that area can rent breast pumps and have breastfeeding supplies. And then in Pass Christian is Gulf Coast Breastfeeding Center, and that is Stephanie Gable's office.
We often get asked about the cost of breast milk and how that compares, and wouldn't formula just be cheaper? But the truth is, for a NICU, a lot of studies have shown that breast milk is actually cost effective. The average cost of one day in a level 3 NICU here locally anyway is about $3,300. But the average cost of donor milk, including fortification if that's necessary for an entire hospitalization for a premature infant, is about half that. So for every dollar that gets spent on donor milk, a hospital is saving between $11 and $37 on NICU cost. So yeah, it is very cost effective. Even insurance companies that have done their studies have found the same thing. To put it in perspective, one case of surgical necrotizing enterocolitis where the baby ends up having to have a colostomy can cost over $650,000. So using free formula from a formula company that gets provided for quote free isn't very free in the long run. In Mississippi, most of the delivering hospitals are now actually using donor milk, and we've just begun serving a couple of these in recent months. But all of the delivering hospitals here in Jackson are using donor milk and have been since we opened. Baptist Medical Center, Merritt Women's, and Merritt River Oaks, St. Dominic, Merritt Central, and UMC have all been using donor human milk from us since we opened. Memorial Hospital at Gulfport is now getting their milk from us, even though they've been using donor milk from one of our sister banks while we were still a depot for them. Forest General, of course, they're baby friendly now, and they've been ordering from us for quite a while. Merritt Wesley is using milk from us now, as is Delta Regional Medical Center in Greenville, and that's one of our most recent ones that we're so happy to have online and be serving them now. So what can you do to help us? Well, depending on whatever your role in healthcare is, you can spread the word, tell your colleagues and staff about our work, answer their questions, answer patients' questions about where the milk comes from or how they can donate. Help us recruit donors. We have some brochures we'd be glad to put in the mail to you about how to become a milk donor. Follow us on Facebook. Visit our website, and you can see that there. Volunteer with us. We have all kinds of volunteer positions, from helping us fundraise or helping us around the office to actually coming in and being a volunteer pasteurization technician. You can scrub in with our crew if you want. You can help with dispensing. You can be a volunteer courier for us to one of the hospital clients that we serve. And of course, we're nonprofit, so we always need money because we've always got a pretty high electric bill to pay with all those freezers.
One thing I'd like to add about the volunteering, this past year we have had a number of NICU nurses in the local area who are needing community service hours because they're going back to school, come and volunteer and actually scrub in the lab, see how all of this works together, and then they leave here knowing how that bottle of milk they use every day in the NICU, how it got to them. That's been very impressive. Also this past year, the entire neonatal fellows from university all rotated through here and scrubbed in, and they were kind of blown away about where the milk comes from that they actually order for those babies. So it's been a great way to educate people hands-on, because you kind of think you know how we work, but until you come here and see it and get your hands in it, sometimes you didn't really understand it. So we would welcome anybody to come and spend a day with us.
Even if you can't scrub in, we've got observation windows that you can watch through if you just want the quick tour, but really want to see how we work. And there's some pictures of some of our folks. In that top picture, I believe they were putting together some packets for potential donor moms, and then we've also had people help with our fundraisers. Financial contributions, of course, the unrestricted gifts that we can use for anything from buying supplies to paying the light bill are appreciated. If you would like to contribute to us but don't have the spare change yourself, you can register your Kroger card to donate to us, and that doesn't cost you anything, but they send us a check quarterly, depending on how much you spend. If you've got a teenage boy at the house like I do, that's a great way to contribute a hefty little sum without having to spend extra yourself. We have some other giving programs that you can enroll in. We have Gift of a Day, which covers the operating expenses for one day, and that's around $2,000. Milk Run sponsorships, we just had a very successful Milk Run 5K about 2 weeks ago that raised about $12,000, so that was great to help supplement our Kellogg grant funding. We also have a thing called the Rosebud Fund, which is our indigent care fund. This is not fully functional yet because we have to have a minimum amount to deposit, but when we get that up and running, it's in memory of Dr. Jack Rawson, who was the father of neonatology in Mississippi, if any of you remember him, who died a few years ago. But when this gets up and running, the funds will be used to cover the cost of milk for outpatients, for instance, a NICU graduate who perhaps had NEC and ended up with a colostomy or short gut syndrome, and now he's being cared for at home, and human milk is still vital for his survival. If his insurance does not cover that, then this fund would cover the cost of that so that his family would not have to sustain that cost. Another example would be babies or small children with certain metabolic syndromes for whom human milk is absolutely essential for survival. So we are saving babies one at a time and one drop at a time, but you can help us make the difference in all kinds of different ways. And there's an example of the size baby that we're typically feeding. And there's another one. But the babies are why we do what we do. And of course, we all think every child is priceless. And everything we do is for the babies. Any questions?
If anyone has a question, they might be muted, so you can hit #6 if you're trying to talk and there's no one hearing you.
Hello?
Yes.
Hi, you have a question?
Hi. I have a question. I have lately, again, gotten several phone calls from mothers who want to see about getting milk. Do you have any milk available for mothers in the community, or are we just giving to NICU mothers at this time?
Just NICU mothers at this time. I get those same phone calls, and although we would love to be able to provide milk for every situation, for every family, there just isn't enough volume to do that. If every person, every mom who sold her milk to a for-profit milk bank would donate her milk to a nonprofit milk bank, that could change. And so that's why it is so important. But the NICU babies are our first priority. Second priority, when we get it set up, will be outpatients, as Becky explained, who absolutely have a medical necessity for human milk.
Okay. So a medical condition that the baby wants only breast milk.
Correct. And then at that point, they would have to have the baby's physician would have to write a prescription, but we're not doing that right now. We don't have enough volume to do that right now.
Okay.
Some of our sister milk banks in Himbana are serving outpatients, and at this point, if we hear of a baby in Mississippi that has that medical necessity, we're still referring them to a sister milk bank in a neighboring state.
Okay. That sounds good. Thank you.
Mm-hmm.
Does anyone else have any other questions? Remember to hit #6 to unmute if you're trying to ask a question. Does anyone have any questions about the CHAMPS announcements from the beginning of the webinar? Okay. Seems like everyone's being really quiet. Oh, does someone have a question? I heard something.
I do. I recently read an article about the disparities that have been found in some other places around babies, African American babies being less likely to receive or be prescribed human milk. And I was wondering, are you all collecting any demographic information, or do you have any policies in place to prevent that from happening here in Mississippi?
We don't know what baby the milk goes to. Once the hospital orders the milk, and my gut feeling is that that is not the case. It doesn't matter. If the baby has the medical needs, then that's the baby who's going to receive the milk. So I would say, at least here, that is not true.
We get an order for X number of bottles of milk for the hospital needed on a certain number of days. We don't know who the patients are that it's going to. That kind of data would need to be collected at the hospital level.
Right. Okay, thank you.
Great questions. Does anyone else have any questions? Okay, it seems like everyone's being very quiet. So I guess we can end a little bit early today if no one has any questions. These slides will be up, these slides are already up on our website, and the recording will be up this afternoon. And just remember to join us for our next webinar in November. Dr. Lori Feldman will be talking about becoming a breastfeeding-friendly office practice. So spread the word and invite people to join us for that one in November. So thank you so much to Becky and Linda for presenting today. And everyone have a great afternoon.
Thanks so much. Enjoyed it.
Thank you.
Thank you. Bye.